Hello, everyone. Welcome to another edition of Dr. Ife's Hematology and Blood Transfusion Science Lecture Series. For some time now, we've been discussing iron. We've looked at iron metabolism, iron absorption. We've treated regulation of iron homeostasis. And the pathological side, we've looked at iron deficiency anemia. If you have not listened to these lectures, please go to our channel and listen to them because it will help you to understand what we are going to treat today better. Today, we are going to have another exciting lecture. It also concerns iron, hemochromatosis, iron overload. If you have not hit the subscription button yet, please feel free to do so. Thank you for your support so far. I am sharing my slide with you. Remember, today's lecture is iron overload, hemochromatosis. My name is Dr. Ifeanyi Mary Ann Okafor, a lecturer in the Department of Hematology and Blood Transfusion Science, Faculty of Medical Laboratory Science, College of Medical Sciences, University of Alabama. At the end of this lecture, it is expected, that you should know how to define hemochromatosis. You should know how to define hemochromatosis. You should be able to explain different types of hemochromatosis. You should be able to explain different types of hemochromatosis, mention symptoms of hemochromatosis, understand the laboratory diagnosis of hemochromatosis, and also have a good understanding of why we need to do genetic testing for patients and also for family members who have hemochromatosis, and of course, management of hemochromatosis. What is iron overload? What is iron overload? Iron overload is a disease that is more clinically known as hereditary haemochromatosis, in which the body absorbs more iron from the gut than it loses, causing the mineral to accumulate in specific areas of the body and subsequently causing organ damage. It is a pathological state in which the total body iron stores are increased, often with organ dysfunction as a result of deposition of iron. In hemochromatosis, the body absorbs more iron from diet, from gut, and as subsequent to this, iron is deposited in various organs of the body, causing organ damage. It is a pathological state in which the total body iron stores are increased, often with organ dysfunction as a result of iron deposition. What are the causes of iron overload? What are the possible causes of hemochromatosis? The possible causes of hemochromatosis, we have genetic causes. This as a result of mutation in various genes that has to do with iron metabolism, especially genes that are connected to Hepcidin. Remember, Hepcidin is the primary protein that regulates iron absorption, either from the duodenal enterocyte or the release of iron from ferritin and hemosiderin in the hepatocyte and macrophages. So mutation in genes that has to do with synthesis of that particular protein can cause iron overload. Another thing that can cause iron overload is non-genetic causes. We have absorption of excess dietary iron intake from our diets, excess dietary iron intake, and diseases that can expose an individual to receiving excess blood transfusion, like thalassemia in patients with thalassemia, patients sickle cell anemia, or in some diseases that affect liver cirrhosis as a result of too much intake of alcohol and other things can also induce iron overload. So we have basically two causes: the genetic causes in form of mutation, mutated genes, and the genes that can be mutated are HAV genes, Hepcidin antimicrobial peptide gene, hemojuvelin gene, transferrin receptor gene, and ferroportin gene. All these genes that I've mentioned here have one thing to do with iron regulation, iron metabolism, and we have non-genetic causes, excess dietary iron and excess blood transfusion. Types of hemochromatosis. Types of hemochromatosis. We have the genetic, based on the causes that we mentioned, genetic causes and non-genetic causes. We basically have two types of hemochromatosis. The one we call primary or hereditary hemochromatosis. Primary hereditary hemochromatosis. This type of hemochromatosis exists primarily as a result of gene mutation. It exists primarily as a result of gene mutation. We have the non-genetic type. The non-genetic type that is called acquired or secondary hemochromatosis. Acquired or secondary hemochromatosis. It is as a result of having excess absorption of iron from our diets or being exposed to excess blood transfusion. One thing with non-genetic or acquired or secondary hemochromatosis is that when the underlying causes are removed, the patient becomes normal. When the underlying causes, the patient becomes normal. But with primary hereditary hemochromatosis that occur as a result of gene mutation, once the individual develops hemochromatosis, the management is for life. The management is for life. So we have primary hereditary hemochromatosis and acquired secondary hemochromatosis. The hereditary hemochromatosis are divided into 4 different types. Hereditary hemochromatosis are divided into 4 different types. We have type 1. The type 1 occurs as a result of mutation in HFE gene. We have type 2. Type 2 occurs as a result of mutation in Hepcidin antimicrobial gene and hemojuvelin gene. Type 2 hemochromatosis can further be divided into type 2A and type 2B. Type 2A occurs as a result of mutation in hemojuvelin gene, while type 2B hemochromatosis occurs as a result of mutation in Hepcidin antimicrobial peptide gene. Another type of hemochromatosis is type 3 hemochromatosis, hereditary hemochromatosis. The type 3 hereditary hemochromatosis occurs as a result of mutation in transferrin receptor gene, while type 4 hemochromatosis occurs as a result of mutation in ferroportin gene. Now, the hereditary hemochromatosis, type 1, type 2, type 3, type 4, as I mentioned earlier, can be grouped into 2 types. The HFE gene hemochromatosis and non-HFE hemochromatosis. The HFE hemochromatosis, type 1 hemochromatosis, is an example of HFE hemochromatosis. It is hemochromatosis that occur as a result of mutation in HFE gene. HFE gene, is hemostatic ion regulation gene. HFE gene is hemostatic ion regulation gene. A mutation that occurs in this gene causes HFE hemochromatosis, which is also called type 1 hemochromatosis. We have another group of hemochromatosis that are called non-HFE hemochromatosis. These ones, type 2, type 3, and type 4 hemochromatosis are under this subgroup. And it occurs as a result of mutation in the genes in HAMP gene, that is Hepcidin antimicrobial peptide gene, hemojuvelin gene, Transferrin Receptor gene, and Ferroportin gene. The mutation that occur in these 4 different genes causes non-HFE hemochromatosis, and they are type 2 hemochromatosis, type 3 hemochromatosis, and type 4 hemochromatosis are under this non-HFE hemochromatosis, while type 1 hemochromatosis is also known as HFE hemochromatosis. Let us take a closer look at type 1 hemochromatosis, which is also known as HFE hemochromatosis. It occurs as a result of mutation in the HFE gene, and it is an autosomal recessive condition associated with excessive absorption of iron. It is an autosomal recessive condition associated with excessive absorption of iron. It is the most common form of hemochromatosis. It is the most common form of hemochromatosis, and it accounts for over 90% of cases. It accounts for over 90% of cases of known hemochromatosis. And onset, it is found mostly in adulthood. The onset starts in men from between 40 to 60 years, while in women it starts mostly after menopause. It is found mostly in postmenopausal women. Career rate is about 1 in 7 to 10 in Caucasians. Incidences is about 1 in 200 to 400, and penetrance is low. Penetrance is low. The HFE gene is situated on the short arm of chromosome 6 at position 21. And the 3 most common mutations that are associated with HFE hemochromatosis are the C212Y mutation, the C212Y allele, the H63D allele, and S65C allele. The HFE membrane protein is similar to the protein of major histocompatibility class 1, major histocompatibility complex class 1, and it binds beta-2 microglobulin. The HFE is needed for normal hepatic synthesis and regulation of hepcidin. When we did iron regulation, I said that the chief protein that is responsible for regulation of iron absorption, either from the proximal duodenum or release of iron from ferritin that is stored in hepatocyte, or ferritin and hemosiderin that is in macrophages, the chief protein that is responsible for regulation of this iron absorption and iron release from this thing is hepcidin. So any alteration in synthesis or regulation of hepcidin will surely affect iron absorption. So HFE gene is needed for normal hepatic synthesis and also regulation of hepcidin protein. So when there is mutation in HFE gene, the HFE protein that is produced is altered, and makes it unable. This makes the protein unable to properly regulate hepcidin, and the result of this is the regulation of hepcidin regulation, ion absorption regulation is altered, is faulted, and there is excess ion absorption, which leads to subsequent deposition of ion on different tissues and organs of the body. So HFE gene mutation produces altered HFE protein, which is unable to properly regulate hepcidin, resulting in an excess of ion storage in tissues. So type 1 hemochromatosis, also known as HFE hemochromatosis, occurs in adulthood, and it normally occurs between 40 to 60 in men, and is mostly found in postmenopausal women. Let us take a closer look at type 2 hemochromatosis, type 2 hereditary hemochromatosis. The type 2 hereditary hemochromatosis is type of hemochromatosis that occurs as a result of gene mutation in hepcidin antimicrobial peptide gene and hemojuvelin gene. The hepcidin, this can also be called type 2 hemochromatosis. Type 2 hemochromatosis is also known as juvenile onset disorder. This type 2 hemochromatosis can also be called juvenile onset disorder because the symptoms often begin in childhood. So it can also be called juvenile hemochromatosis because the onset of the disease starts from childhood. By the age 20, iron accumulation causes decrease or absence of secretion of sex hormones. But in females that are affected, they can start menstruation, but this will eventually stop. Now, we say this type 2 hemochromatosis is caused by mutation in hepcidin antimicrobial peptide gene and also mutation in hemojuvelin gene. Therefore, under type 2 hemochromatosis, we have subtypes, type 2A and type 2B. Mutation in hepcidin antimicrobial peptide gene causes type 2B hemochromatosis, type 2B juvenile hemochromatosis, type 2B juvenile hemochromatosis. Remember, we said that this type 2 hemochromatosis can also be called juvenile hemochromatosis because it starts from childhood. Genetic alteration in HAEMP gene compromises hepcidin function. Because you remember when we are treating iron regulation, we said that hepcidin, the production of hepcidin is regulated by a gene called hepcidin antimicrobial peptide gene. So alteration in this gene will definitely do what? Affect hepcidin function. The HAEMP gene is located on chromosome 19. Polymorphism present in HAEMP gene are less frequent than polymorphism in the HFE gene. Currently, we have about 16 different types of single nucleotide polymorphism, but in HAEMP gene, that is hepcidin antimicrobial peptide gene, but only few of this is present, has been described, or have been implicated in hemochromatosis. We have one C780 mutation, R56X allele, G71D allele. Association of HAEMP and HFE gene polymorphism can occur occasionally. Genetic alteration in the HAEMP gene may cause a defective or truncated hepcidin, making its mechanism of action impossible. Remember that Hepcidin antimicrobial peptide mutation causes juvenile hemochromatosis type 2B. Hemojuvelin gene mutation. The hemojuvelin gene mutation causes type 2A juvenile hemochromatosis. Hemojuvelin gene mutation causes type 2B, type 2A juvenile hemochromatosis. The hemojuvelin gene or HFE2 gene encodes the hemojuvelin protein present on chromosome 1, long arm of chromosome 1, position 21. The hemojuvelin is expressed in the liver, heart, and skeletal muscles. The hemojuvelin transcript has 5 isoforms, with the longest protein having 426 amino acids. Hemojuvelin is a co-receptor of bone morphogenetic protein, and this protein is needed for proper regulation of hepcidin functions. So hemojuvelin is a co-receptor of BMP proteins, which binds to BMP receptors to increase SMAD phosphorylation. Genetic alterations in the hemojuvelin gene makes it impossible to transcribe hepcidin. In this way, parenchymal and tissue iron accumulation occurs in the first decade of life and is classified as juvenile hemochromatosis type 2A. Currently, there are about 43 hemojuvelin gene mutations. About 4 different mutations on this gene have been identified, and these genes can cause juvenile hemochromatosis. But the most common of them is G320V allele, is the most frequent. In this particular gene mutation, there is exchange of glutamate by valine. Remember, the onset of hemochromatosis due to mutation in hemojuvelin gene, which causes type 2A form of juvenile hemochromatosis, is childhood. It starts at childhood level, and therefore it is the same as mutation in hepcidin antimicrobial peptide gene that causes type 2B juvenile hemochromatosis. The type 3 hemochromatosis, that is the hereditary hemochromatosis that is formed as a result of mutation in transferrin receptor gene. It's called type 3 hemochromatosis. The gene encoding the transferrin receptor type 2 is located on chromosome 7. The transferrin receptor 2 is a member of transferrin receptor family. When we are treating iron metabolism, we said that transferrin receptors are found on the surfaces of cells that need iron. And what they do is to form a complex with transferrin. Transferrin is the protein that transports iron in the plasma. So when transferrin carries iron from plasma to these cells, the transferrin receptor on the surface of these cells forms a complex with this transferrin and internalizes this iron within the cell through a process of endocytosis, so that this iron, the mitochondria that is within the cell, can have access to this iron to form hemoglobin. So transferrin receptor is expressed in the erythroid tissue, where it is a component of erythropoietin. Where it is a component of erythropoietin receptor necessary for effective erythropoiesis to occur. The homozygous nonsense mutation at the 7q23 locus of the transferrin gene leads to a rare form of iron overload called hereditary hemochromatosis type 3. The onset of type 3 hereditary hemochromatosis is usually intermediate between type 1 and type 2. Remember, type 1 occurs in adulthood, Type 2 occurs in childhood, while type 3 is intermediate, with the onset being at about 30 years of age. The onset of symptoms occurring at about 30 years of age. Transferrin receptor gene is required for phosphorylation of bone morphogenetic protein 6 in response to iron levels, playing a prominent role in the signaling pathway of Hepcidin antimicrobial peptide gene and HFA gene. Ferroportin gene mutation, type 4 hereditary hemochromatosis. The mutation that occurs in ferroportin gene causes type 4 hereditary hemochromatosis. Followed carrier family 14 member 1 gene located on chromosome 2 codes for ferroportin proteins. And when we are treating iron metabolism and iron regulation of iron absorption, we said that ferroportin is a special channel through which iron is allowed to enter into the circulation at the duodenal enterocyte. And also at the level of storage, ferroportin is also a channel through which iron, which is stored in the ferritin, in the hepatocyte, are allowed to enter into the circulation. The same thing in the ferritin found in macrophages and as form of ferritin and then hemosiderin. The iron content of these two proteins are allowed to enter into the circulation only when they pass through this channel, ferroportin. So in regulation of iron homeostasis, what hepcidin does is to try to block this channel ferroportin. Once it is blocked, iron will not be absorbed through the enterocyte, and then ferritin might not be able to release iron into the circulation. So if there is a mutation in this particular, in the gene that codes for this particular protein, ferroportin, it will definitely affect iron absorption. Alteration in this gene gives rise to a disease called the ferroportin disease. And it is an autosomal dominant disease with two forms. The type of hemochromatosis that occurs as a result of mutation in ferroportin gene can be divided into classic form, which is also can be also said to be type A form, and non-classic form, which is can also said to be type B form. Although this type of hemochromatosis is rare, type 4 hemochromatosis is the second major form of iron overload after hemochromatosis due to HFE gene mutation. The classical form of the disease is usually asymptomatic, without tissue damage, and without other complications in young life. With age, damage to the liver and pancreas may occur with development of fibrosis and low hemoglobin concentration. There are mutations that can take place that can cause this type 4 hemochromatosis. The mutation that can take place in ferroportin gene that can cause type 4 hemochromatosis are A77D allele, D157G allele, as stated on the slide. And again, the classical mutation, the non-classical or B form of ferroportin is more rare and similar to hemochromatosis type 1. The non-classical and or B form of ferroportin is more rare and similar to hemochromatosis type 1. Then we have mutations in N144H allele, Y64 allele, and the rest that are related to this disease phenotype. Remember that we said that onset is like that of type 1 hemochromatosis. It occurs in adulthood, mostly between 40 to 60 years of age. Mostly between 40 to 50 years of age. Let us discuss inheritance. Let us look at the inheritance of how do we inherit this mutated gene. The inheritance follows the Mendelian law of inheritance. What it means that if one of your parents is carrying this gene, it's most likely that the offspring will get it. Type 1, type 2, type 3 hemochromatosis are autosomal recessive disorders. Type 1, type 2, and type 3 hemochromatosis are autosomal recessive disorders. This means that diseases can only manifest in homozygous form, while those individuals who inherit it in heterozygous form are called carriers. It is called type 1, type 2, type 3 hemochromatosis are autosomal recessive disorders. It means that somebody can only be susceptible to disease when it has inherited the mutated gene from both parents. But when you inherit only one mutated gene from one of your parents, that means you have it in heterozygous form. You are a carrier. Type 4 hemochromatosis is an autosomal dominant disease, indicating that patients can manifest the disease even in heterozygous form. Type 4 hemochromatosis is autosomal dominant disease, and what this means is that patient can do what? Manifest the disease even in heterozygous form. Let us look at autosomal recessive inheritance. As shown on the slide here, this is the parent, both of them being carriers of the mutated gene. Both of them being carriers of the mutated gene. They have 4 offspring. One of the offspring does not have any form of the mutated gene, so it's unaffected. We have the 2 offspring being carriers. They have 1 mutated gene each. And then we have only one of the offspring having the double, inheriting the mutated gene from both parents. And then this person is said to be susceptible, to have the susceptible genotype for hemochromatosis. This particular offspring here is said to be susceptible to developing a hemochromatosis. Symptoms. What are the symptoms of this disease, hereditary hemochromatosis? We have classic triad. The 3 basic things that clinically, when present clinically, you can say that this person, you can strongly suspect that this person is having hereditary hemochromatosis. But the sad thing is, by the time this particular symptoms present itself, organ damage may have occurred. And at this stage, even when you try to manage the disease, you may not be able to reverse the organ damage. So our goal at any point in time is to try to detect the disease before organ damage. So the 3 triad is 1, cirrhosis, liver cirrhosis, that is hepatic damage, diabetes type 2, that is pancreatic damage, and then bronzing of the skin, that is hyperpigmentation of the skin. These 3 things is a strong suggestion that when present clinically, is a strong suggestion that the person is having a hereditary hemochromatosis. That is liver cirrhosis, that is hepatic damage, diabetes type 2, having pancreatic damage, and then hyperpigmentation, that is bronzing of the skin due to iron that have been deposited in different tissues and organs of the body. Remember that traditionally, when this is seen, it means that diagnosis is already too late, and damage may be only partially reversible. So the goal at any point in time is to diagnose it, detect the disease before organ damage occurs. Now we have another clinically non-specific symptoms and signs that you can see, and then it is suggestive of hemochromatosis. In the liver, you have hepatomegaly, and then elevated liver enzymes is indicative of this. Then in the cardiac region, you have myocardial infarction, cardiomyopathy. In endocrine region, you have impotence, amenorrhea, diabetes, and then musculoskeletal region, we have arthritis, arthralgia, and then we have unexplained fatigue. It can be severe, it can also be chronic. It can be severe and chronic. But one thing to note is generally that these symptoms may not be evident until maybe 40 to 60 years of age for type 1 and type 4 hemochromatosis. And It occurs much earlier in type 2 because it is juvenile hemochromatosis. While in type 3, it occurs around 30 years of age. Now, in the laboratory, what are those tests that we do in the lab that will help us diagnose the hemochromatosis? The tests that we do in the lab, first of all, in addition to complete blood counts, full blood count that we do and looking at peripheral blood flow, we also, the specific test that is diagnostic of iron overload or hemochromatosis is transferrin saturation that is above 45%. That is percentage transferrin saturation that is above 45%. Is suggestive, is strongly indicative of significant iron accumulation. Then serum ferritin. When you do serum ferritin, estimate serum ferritin level for premenopausal women, serum ferritin level that is above 200 microgram per liter. Postmenopausal women, serum ferritin level that is above 300 microgram per liter. And then for men, serum ferritin level that is above 300 microgram per liter is actually indicative of hemochromatosis, that is significant iron accumulation in the body. Then the next thing that can be done to aid the diagnosis of hemochromatosis in the lab is a liver biopsy. And this is done when ferritin is more than 1,000 microgram per liter. And this is, liver biopsy is done to assess liver damage. When you have done all these things, then the next thing you should consider doing is to do what? Consider genetic testing. It is important to order for genetic testing. DNA testing for common mutations. If you have a common mutation that has to do with type 1 hemochromatosis, type 2 hemochromatosis, type 3 hemochromatosis, and type 4 hemochromatosis, like indicated on the slide there. Now, genetic testing for hereditary hemochromatosis should be offered to those patients with one, appropriate clinical presentation. That is, you must have looked at the doctor must have looked at it clinically and have stated that they have those symptoms that we stated earlier: liver cirrhosis, pancreatic damage, that is diabetes, and then hyperpigmentation of the skin, and then extreme fatigue. And then you must have done laboratory testing and found that it has elevated transferrin saturation and elevated ferritin, as stated earlier. And then liver biopsy should suggest iron overload. So what you must have done is, the next thing to do is to order for genetic testing for the patient. Another people that can also be exposed to genetic testing are first-degree relatives of a known case. Relatives of a known case can also be, introduced or allowed to do genetic testing. And genetic testing must be offered to an affected family member, or in this case there, first. A known mutation should be identified before offering DNA testing to other family members. Now, what is the value of genetic testing? Why do we need to do the genetic testing? First, to confirm what? Diagnosis. You've already looked at the clinical presentation, you've already done the laboratory diagnosis, then to confirm what you have done, and also to find the root cause, the gene that is implicated in that hemochromatosis, you confirm with genetic testing. And then it also helps you to do the sequential screening of family members so that you can prevent in future and also offer them advice and modify their life style. Like family members with identified mutation can be offered screening plan to monitor for iron overload, normal life expectancy if diagnosed before diabetes mellitus and liver cirrhosis, treatment plan to prevent further organ damage and morbidity or mortality, prolonged survival with serial phlebotomy, and trying to make their ferritin level to be between 50 microgram per liter. And then offer them environmental modifications like in diet, alcohol intake, and then making sure that the they immunize themselves against hepatitis A and hepatitis B. So basically, for a non-patient of hemochromatosis, offering genetic testing to the family members is actually for preventive measures, so that if they are found to be susceptible to the disease, they can have lifestyle changes that will help them not to develop the disease in future. Discussing genetic testing. Before you carry out the genetic testing in the individual, there is need for you to get the consent of the patient involved or the family member involved, and there should be detailed explanation of the risk, the benefit, and the limitation of the test should be made known to the individual to undergo the test. And then you should be able to walk the patient through various scenarios, the positive result of the test and both the negative result of the test. You should be able to walk the patient through various scenarios, the outcome of the test, when the result is positive, when the result is negative. So the patient should be prepared psychologically, emotionally, on receiving the result of the test. Then psychosocial issues should also be discussed with the patient, the self-concept, the assurance, discrimination, family issues, and non-paternity issues. Things like that can also be discussed with the patient. Everything should be made known to the patient, the risk, the benefit, and the limitation of the test before you undergo the genetic testing. Now, having done all that, the question now is, so if I have the gene, will I get the disease? Assuming that I have not developed the disease proper, and I have a relation that is suffering from the iron overload of hemochromatosis, hereditary hemochromatosis, and I'm offered genetic testing. Now, if I have the gene, must I develop the disease? The answer is no. If you have the gene, you must not develop the disease. This is because of what we call incomplete penetrance. Incomplete penetrance. Now, penetrance is the proportion of individual with a mutation causing a particular disorder who exhibit clinical symptoms of that disorder. Penetrance is the proportion of individual with a mutation causing a particular disorder who exhibit the clinical symptoms of that disorder. So that even though some individuals have the susceptible gene, they have the susceptible genotype, they may never manifest symptoms of that particular disease. And this may be due to environmental factors, lifestyle, the way you live. In this particular particular study that we're having today, hemochromatosis, you being able to intermittently donate blood will also help you to give up some of the, iron that you have, especially men. It's advised in men that because you don't have any, we don't have any physiological, body doesn't have any physiological means of losing blood, So women, because of monthly menstruation, one way or the other, lose some significant amount of blood monthly. But men, apart from sweat, the one that is given off, which is a very little amount given off during sweat, men does not really have any physiological means of losing blood, unless you have underlying ailment that allows you to have blood loss. So most times it is even good for both men and women to donate blood intermittently. It helps you to keep healthy. So lifestyle modification can also make somebody, even though you have the gene, you may never develop the disease. Then you have genetic factors or other modifying genes that also can make an individual, even though you have the susceptible gene, but may never develop the disease proper. Management of hereditary hemochromatosis. How is it managed? Remember, the goal is to dictate patients before symptoms of iron overload. Because we said that most times, once you have those classic triad symptoms like cirrhosis, hepatic damage, pancreatic damage, hyperpigmentation, at that time, organ damage may have occurred and reversal may be impossible. So most times, it is good to do what? That's why the need for annual checkup or frequent medical checkup can never be overemphasized, because if this disease is picked earlier, then it can be prevented from damaging any of the organ or tissues. But medically, it can only be treated through phlebotomy. Weekly or biweekly phlebotomy is offered to the patient, and then frequent taking of ferritin level, is also offered to the patient. And then phlebotomy is stopped when the ferritin level is between 25 to 50 microgram per liter. That is, weekly phlebotomy may be stopped, and maintenance phlebotomy will be introduced maybe 3 to 4 months. 3 to 4 months is offered to the patient to maintain ferritin level around between 25 to 50 microgram per liter. And then patients can also be offered the dietary modifications. Recommendations should be given in terms of diet on how to modify their diet to live a healthier life. And of course, the patient should be closely monitored by a clinical hematologist. The patient must be closely monitored by a clinical hematologist. Thank you very much. This is my references. And then resources for further reading. Thank you. I have had an exciting time, and I'm sure that you have also had an exciting time. Remember, we treated hemochromatosis, and I'm sure that by now you should be able to define hemochromatosis, mention the different types of hemochromatosis, and say something about the types of hemochromatosis we have, the clinical presentation, and laboratory diagnosis of hemochromatosis. And again, why we need to do genetic testing for individual that has a hemochromatosis. Thank you very much. Thank you. And